Okay, Assalamu alaikum. First of all, thank you for coming and welcome to this session. This session is mainly going to be introducing a new aspect of healthcare informatics and what we can do. For this session, we have invited Dr. Syed Ahmad Chan Bukhari. He is assistant professor and director of healthcare informatics department in St. John's University, New York. Basically, he is PhD in computer science from the University of New Brunswick, Canada, and he has completed his postdoc from Yale Medical College, Medical University. So I will be inviting Syed Ahmad Chan to start his talk, which is about predicting healthcare outcomes using machine learning to foster safety, quality, and value in clinical care.
मीट खोला है रिकॉर्डिंग ऑल टैप कर ये अपनी फुल स्क्रीन जो है मीट वाला टैप कर दी वो वाला कर ये प्रेजेंटेशन वाला जी
Day. Assalamu alaikum, good afternoon. Thank you, Dr. Hatak, for the invitation. So today I'm going to present my work about predicting health outcomes using machine learning to foster safety, quality, and value in clinical care. So I would like to start with the introduction and probably come to you to share your knowledge. How we can, sorry.
Just press next.
Next? Yeah, I see. No, I'm present. Okay. I am pressing next.
No, not on.
Okay.
Next.
Next. Okay, cool. Thank you. Anybody has any idea about outcome research? No? So with the outcome research, we basically try to understand the end results of particular healthcare practices and interventions. What this means, particular healthcare interventions, you see a patient when in a usual setup, we go to hospital. What would be the possible outcomes of that hospital visit? We either get cured, and sometimes we need hospital readmission, and in worst scenario, we will have the mortality or deaths. That we will call, that are some examples of the healthcare outcomes. Now, what is the goal? What is the purpose behind to this outcome research? We say the goal of this measuring, analyzing, and comparing of these healthcare outcomes, or analyzing multiple healthcare outcomes, we would like to achieve number one, the patient satisfaction, meaning how we can improve the patient experience of care. Secondly, how we can improve the health of overall population to overall improve the better care. And the third point is that how we can reduce the clinicians and staff burnout. The staffs, doctors are working in a long shift, 2 days shift, that how we can reduce their burden. developing the clinical decision support system, or developing the assistive technologies that could help in facilitating their work. And last but not least, how we can reduce the per capita cost of the healthcare. Lowering the cost is in the interest of patient, doctors, hospitals, public, federal government. So that's why I would like to elaborate further the fourth point, reducing the per capita cost of the healthcare. Let me give you showing some number. I just would like to uh, give you the idea that how important this point or this variable of per capita of healthcare is. At this time in the US healthcare system, with the total spending more than 70% of the US GDP, they spent on healthcare. 17% per year, which is around $5 trillion. And these $5 trillion are uh, the OECD, the countries like the developed countries from the Norway to Denmark and all countries, like they are spending around, in combined, they are spending 10% of the 5 trillion, right? Just to clarify more that the magnification of this 5 trillion, uh, it's more than or 2 times the value of these big giants. From Apple, now Apple yesterday reached to the 3 trillion, and the Johnson Johnson, Exxon, Google, Walmart. So this the healthcare spending per year has the value double than the total value of these big companies. Now, the question is, with this staggering healthcare cost, with its staggering healthcare services, by the way, everyone in the US healthcare system is totally private. Everyone is spending $200 to the $1,000 every month. Yes, uh, paying as a healthcare. And now the question is, uh, are we getting the right return of the value, the money that we are spending? And our analysis just that uh, people are not happy. The quality value of the healthcare is not that optimal as we all people, those who are spending, are anticipated. Now, another related question is that how we can minimize healthcare services cost. That we saw that the the spending the 17 billion. If we somehow reduce this 17 billion, maybe if we can reduce just 1 point, 2 point, 3 point, that money we can reroute for other public health uh, 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 projects, or maybe we can subsidize to the people, those who are spending that hefty amount every month, right? So with that question in mind, that how we can minimize healthcare services costs, we started looking at the areas or the problems where we can see we are spending most of this 17 percent of the GDP that we are using. So the first uh, is the unnecessary medical expenses. And unnecessary medical expenses, the one of the prime example are which cost more is the hospital readmission. How? Around 20% of patients in US hospitals, they are readmitted, and that cost Medicare around $17 billion. And out of these $17 billion, $12 billion are potentially avoidable readmission, right? So the $17 billion, and out and 12 billion dollars are a wide, and now we have to, our focus is on the 12 billion dollar. Just keep this point in mind. The examples that I'm going to show you next, the use cases, we are the example will show that how we are trying, what like using the IT, using the AI, machine learning, deep learning, how we are trying to reduce or minimize these the healthcare spending in the first case of the hospital readmission. Okay, now the second case is that we have selected is the preventable deaths, right? So the deaths, this chart shows, if you see that the disease from the heart to the cancer to the chronic respiratory disease to the unintentional injuries, and here on the y-axis you will see the number of deaths, around 1,000, even more unplanned death or avoidable deaths every day happen in US, because that's the data is mostly is taken from the US databases and surveys, uh, and data's just around 200K to the 400K preventable deaths in US per year. Now the preventable deaths because of the COVID, I'm sure these numbers are now much bigger. At this time is maybe around billion, but 200K to the 400K preventable deaths because of the heart disease. We can now here come the role of information technology in this data age, that how we can use machine learning and deep learning to early predict the heart failure, to early predict the respiratory illnesses, just like even the not just COVID is just one example of respiratory, and there are several other respiratory like illness, influenza, and others are, and also chronic disease, lung, liver, blood disease that they have. Uh, so how we can, and if we would able to somehow reduce these preventable deaths, and because they are burdening the US healthcare system, we definitely can save a lot of money. And as I said, these money could be then rerouted to lower down the overall spendings of individuals, that we people are spending like $200 to the $1,000 per month. And the when I say the role of information technology in this data age, so all you are all computer science students, you know that the everyone is familiar with the word of with the big data. And when we talk about the big data in healthcare, just to give you the idea that how exponentially the data is growing in the healthcare sector, if you see the chart, this pipe or bar chart on your left side, so in 2012 we have around 153 zettabyte of data, which is now around more than 2,500 zettabyte of data, and growing. And by the way, 1 zettabyte of data is equal 1 billion gigabyte. So it's a lot of data. What I believe that this big data could lead to a better healthcare and with lower cost. But this big data will come with a lots of technical challenges, caveats that as a computer scientist we need to solve. Uh, Now, where the big data in healthcare comes from, you see here this there are several bubbles around this rounded rectangle. Starting from the generic databases, we have the databases about the genes, protein, pathway databases. There are several others. There are around more than 2,500 different types of the biomedical or biological databases. Then we have some data available in the form of research studies. Uh, we have the paper available on PubMed, Google Scholar, Archive, BioArchive. Then we have the patient portals, just like the patients like me, where the patients share the information with other patients just to get some tips and tricks, and the just sharing their happenings. And then we have the data available of some free available data in the government agencies, just like in the CDC we have the data available in the FDA. Then the another important source of the data is the payer record. We have the insurance agencies, as I mentioned at the beginning, that all the procedures being like your treatment, whatever whatever you done in hospital settings, that will go. And like majority of the people, as in US, they have the insurance, are covered to an insurance system, health insurance system. uh, so they have the record of the patient, different types of the record. I will show you with the examples of the data which they hold, from the demographic informations to the patient clinical labs and other information. Then you and me both have the smartphones, and you see every day we count our steps, we count our BMI, and every day the apps are being developed that could help us in for the personal health or physical management. And then we have the wearable devices, like other than that, like Fitbits and others. Uh, and then we have the search engines available, that particular health, even Google, they have now the search engines for the health data explorations. And we have the BioCaddy and several others, the search engines available at this time. Now, what I mean to show all you to this, that we have a number of sources and many more. We have the sensors data coming directly from the patient beds. So with all these countless sources of data is growing very, very fast. and and also, I believe you are all familiar with this 5V, some 6V of big data. So we have the data which is available in general data or in the health data. We have one factor is the velocity, which we call the data is coming, like how it's coming, like in a batch format, in a process format, in a stream. Then variety of the data is available, like the healthcare, we have the images data available, sounds data, ECG data, structured and unstructured type of data available. Then we have the volume. I just show you the examples, like the terabyte, a zettabyte of data is available. Now, another important thing is the veracity from which the data is coming from. Is it coming from a legitimate source, or is this just a noise, or it's what's the authentication? What is the source of that data? It's the veracity. Then we have the data that we can classify based on its value, and then we also have the variability factor. With that, when we see as a whole, we find that this big data or big domain is incomplete. Data is incomplete, incorrect, and data is also redundant. Data is also in silos. Silos mean the data is not linked with other data, like the gene data are not linked with the pathways data, and pathways data are not linked with the with other biomarkers data. So the picture is overall is blurry, is incomplete. And when I say that I believe that uh, the big data could lead to better healthcare with a lower cost, we cannot get these lower costs with better care until we would able to solve known and some unknown technical challenges of relating to the big healthcare data. So here comes my group. My group focuses on devising techniques to semantically confederate, to interlink, link, mix, join this heterogeneous type of data which I just showed you. And after that, what we do that we develop different artificial intelligence based algorithms and for clinical outcomes. And no, I believe everyone has a idea that when I use the word clinical outcomes, what I mean that. So the purpose of this whole exercise is that These techniques further alleviate many data access related challenges faced by the healthcare providers or practitioners. All right. With that now, I will start with the first use case that I mentioned at beginning, that we're predicting 30 days all-cause hospital readmission considering discharge to alternate care facilities. Now, why we need predicting 30 days all-cause hospital readmission? In the earlier slides, I have mentioned uh, uh, some parameter factors. Some more here in this slide. Around 20% of Medicare patients readmitted within 30 days of discharge. Just this, probably few of you are not familiar with Medicare and Medicaid. There are two different types of the insurances in US. One is the Medicare, one is the Medicaid. Medicare are the people, those who are old people, and Medicaid are the people, those who are either like with a lower income, and the people, those who are disabled mainly. And if the people they fall in both the categories, then they find where they could get the best health care. But both Medicare and Medicaid are free and is paid by the federal government as we pay them the taxes. Now, the 10.3% unplanned readmission in 30 days. Why we use 30 days, not 35, not 40, not 100 days? Because 30 days, consider you say, um, 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 is one index is normally used there. There is no hard fast logic behind, but they consider that it's a good number of days to consider to compare. Then, and this 41 billion dollar cost of 3.3 readmitted patients. And then, this is not the things that the federal government and the hospitals are not aware of about the hospital readmissions. There are programs just like HRRP, hospital readmission reduction program, and the hospitals, those who early discharge to the patient, the government and federal and non-federal organizations, they find them time to time penalties. So the penalties imposed on hospitals for 30 days readmissions, their penalties no increased by 20% in recent year. Now, what we are studying, we are trying to look at the live one thing. There are three questions. One is likelihood of readmission considering to discharge to alternate care facilities. Like now, one is the one hospital. You see, we have in Pakistan, we have the physiotherapy people, we have the people, those who have, uh, they don't have that kind of range, but over there, they have the different transitionary cares. For example, skilled nursing facility where nurses are available just for the medication. Some also there are some staff are available, those who take care of them, the people, old people, those who cannot even eat or go to the bathroom, so the people are there. So there are different levels of the transitionary and post care. The first point, we are looking for the likelihood of readmission. What is the likelihood of readmission if we can send to the patient to a particular transitionary care based on the demographic factors and the medical history and factors of the patient? The second point is, in general, we are looking for the importance of this discharge to alternate care facility variable, that how this variable is important. The people, those who will directly send to their homes, how likely they will come back, or if we just not directly send them and instead we send the patients to the transitionary care, and then we are looking for that how uh, uh, and comparing them, that how uh, how impactful this process is. And this is third point is the research in progress, that we are looking for the optimal pathways planning from the ICU to the alternate care facilities. But you see that these questions or these studies are very, very important to the insurance agencies, like as these are some list of the private and federal insurance agencies, like from Medicare to you see the names of the United and Care Plus, the Summit. If they could know that like the patient will come back and they will readmit it after 30 days, then they can communicate better with the hospitals, and hospitals they could be aware better, and they could also, this could also help in a resource planning, and that could ultimately leads to the less readmissions. Less readmission means less expenditures, saving cost, and overall healthcare. Now, the discharge planning is a very systematic process, and we divide that into a four part. If you see uh, this pie chart and the arrow around, the first part is the screening. So in the screening part, we determine the appropriate post-hospital discharge destination for a patient. Like I saw you the couple of the transitionary and post-care facilities, like skilled nursing facilities to intermediate care. Uh, the second point is to evaluate the post-discharge need. That to identify this point, we identify what the patient requires for a smooth and safe transitions from hospitals to his or her discharge destinations, to the hospice, to the skilled care facilities. And the third point, we look for the factor of the diagnostic. We incorporate the diagnostics lab, the physical conditions, their social economic factors. Is the person single, or is there any family member who can take care of? And based on that, we uh, plan for the discharge. And discharge planning, there we refer as a process involving a transition from the patient care from one level to the other level, maybe from hospitals to directly home, or hospital to the hospice, or hospitals to the physiotherapist, that based on the factors that we determine. Now, what we did that, uh, we took the discharge locations for previous admissions. For example, like whether the patient were in hospice, in long-term care, in a rehab. Then we took the current admissions and care level, like the type of the admission, total length of stay in a hospital, uh, and admission location. Then also the data about the comorbidities. For example, related disease. For example, if someone came with the diabetes, whether the patient have any heart disease or any other associated disease with that. So the drug severity, drug mortality level, then the demographic informations from the gender to the ethnicity. uh, so here is the distributions. Like in general, we took the gender, ethnicity, some marital status, readmissions, and some discharge location and comorbidity data. Uh, and data is mainly taken by from the mimic database, also some the hospitals data of the patient, but all the data were the identifies anonymized data. And we found that, after refining the pre-processing, we found the patients which where we that they have the readmission record. And afterwards, we applied a number of algorithms, like machine learning models we built. And the idea was that we were looking for a model where we could find the highest predictive power. And we applied the logic, logistic regression, neighbors, random forest, and then we generated the result based on that. And so a confusion matrices and the performance matrices score with the neural network and logistic regression in our experiments appears to have a predictive power in terms of accuracy as well as precision. For example, we found that the result, our result reveals that with this the AUC under area under cover is 0.75 for neural network and 0.73 for the random forest. Uh, what it clears the question which we at beginning raised. With that, it's clear that alternate care has definitely have a role in correctly predicting the 30 days readmission. Uh, with the high recall nearing 0.7, both of these models we believe can be used with the healthcare providers to correctly predict the potential 30-day readmission during a discharge planning phase. So in summary, I can say that our work contributes by developing, we develop a very simple, not always you can use the deep learning, and not always you need to do a machine learning algorithm. It's depend on your use case. Some use case, you can get better result with a very simple machine learning algorithms, and you fail with the deep learning algorithms. And maybe with even there are cases where you absolutely don't need to use the machine learning. So with that data, as we don't have the data, as we are using the real time data, we don't have the data in a large number. So for that, the simple neural network and random forest, we show the showing the optimal performance. This research work done by my students are still under in progress, and at this time we are fixing some known shortcomings and also optimizing the scheme. And such predictive models considering pathways and transitions between alternate care facility should be or would be very interesting for insurance providers due to their coverage and cost implications that's in general we believe. So this was the first case, and you see that if we could predict the uh, hospital readmission, and we could definitely could save a lot of money, which I showed the number at beginning, and that money could be we can utilize for the other purposes. Now going to the second use case that we have, I show you the second use case about the mortality prediction, right? So when we started this work, I was discussing on lunch with folks that when we started this research, we faced a lot of criticism, and the people like those who are absolutely have no idea about the value of this, like they were simply just reading the sentence and thinking that we are predicting the mortality, we are predicting deaths. Uh, uh, the our models that we are trying to build, that we are trying to build a model that could calculate the likelihood of mortality. And you see these use cases are very very real. The doctors in real time in the ICU setting, every day they decide to who they should treat first. You see in the COVID case, we have the case of the vaccines, who will get the first vaccine. There were several ethical questions arises that time, but having such model in place is really really important. I will see you with this case of the mortality prediction. What were the motive behind the why we feel that it's a crucial. So assessing the severity of illness, disease progression, as I show you, the cancer is a second or third leading cause of death. If we can somehow, based on the data analysis, could find the disease progression, or someone may develop the cancer again, like uh, the people they go to remission, and then again, so that we can do that with the help of this such kind of model. Then the case of adjudicating the value of treatment strategy, like what kind of optimal selections of the treatment therapy should be based on the patient conditions and level, and the physical health. And then this kind of research would also help for the resource planning, right? So you see in the wards, that's the examples I was quoting again on the lunch table. In the wards, they see the people, those who receive like more bullets, they know that like this person will die, so they try to pick the people, those who just receive one bullet, or maybe a minor injured or injured somehow, so that they can at least save that person. So the doctors and real time, they also have they always have to deal such kind of situation and scenarios where they have to take decisions very very quick. no more guesswork with this data age. And you see what we can do, that we, even with explainability factor, we can design clinical decision support system that could facilitate doctors, paramedics, those involved in the healthcare to take the intelligent decisions, and not the decision based on just choices and their their likes and guesswork. So our team of the trauma surgeon, internist, and pathologist, computer scientist, we developed two algorithms. First, we developed the flame. Second, we developed based on the deep flame algorithms. And the purpose was that to carefully plan the treatment strategy for critically ill patient admitted to the ICU. And the again the sub use cases are the disease that we picked, that are the paralytic ileus, and the second case was the trauma. Now, just to give you the, as most of you are computer science students, so the paralytic ileus is the obstruction of your intestine due to the paralysis of the instantaneous muscle. It could be due to several factors, like electrolyte imbalance. Some may have the gastroenteritis, overuse of medication, especially antibiotics, abdominal surgery. So the what we have noticed, that the mortality of the patient with the paralytic ileus can be as high as 40% in the ICU setting. And this is the case where we could use IT and machine learning, deep learning, to reduce the mortality, and that's, when we're reducing the mortality, that means we are reducing the expenses and overall, the improving the quality care. And therefore, we realize that there is a need to build or develop a clinical decision support system that could help clinicians in making the right decisions to allocate advocate resources to these patients. And this could also help to the hospital administration as well, to sending to the trained nurses to the people when the particular patient arrives. And the second case is trauma. This we also identify through our analysis. The trauma patient admitted to critical care are at high risk of mortality because of their severe injuries. And in the ICU settings, 10.7% of the people, they usually die. But though these numbers could be reduced if we could utilize the uh, clinical decision support system at the time when the patient arrived, like within 24 hours. Uh, so for that, we took the data from the Mimic DB, which is a database about the ICU managed by the MIT. Around 95 to 100 ICUs data is there. They continuously update that. And then we do the initial screening. We applied the different biostats technique, just like the Cox aggressions, Kaplan-Meier. The Cox aggressions analysis provides the hazard ratio, and after that, we took that the Cox aggressions and used the Kaplan-Meier to basically design the rank order list. If you see that, we found that we have a number of variables, and the doctors, those who are involved, they have selected the 22 out of that. Then, our analysis, we again uh, lowered down and just selected few from 22 to 15. Now, what is the benefit of this? This improves the predictive capability of the machine learning based predictive model, as it reduces the overall complexity of the predictive model, and also by reducing the number of risk factors that need to be processed by the machine learning models, like easily in a short time. That was the significance of the phase one. The data that we will use, that this is the slide of the demographic data. If you see, again, just like the previous experiments, we use the demographic from the age to the ICU state to the gender, data, some admission type of data. Then we used some clinical labs, for example, chemistry labs like the sodium chloride, blood urea nitrogen. Then in hematological factor, we use white blood cell and others. Then in bleeding profile, and then in the serum protein, there are the list is long. So in the paper, I will mention for you to read. You can find all the variables and see that the reasons why we have selected all these. So the data that we obtained that from the ICU, around 46,000 patient with a paralytic alias, we found that the 167. Then we took all the patients with the age over 18, and then we used the univariant, multivariant applied machine learning model. And after that, we got the results. And our results show that the spore vector machine with the RBF kernel showed the better performance with the PI data. And the same with that, in a dim flame case, we found that our algorithm beats all the available at this time our published work, which is on the PubMed. DFLIM can be used as a potential clinical diagnostic marker or the tool for mortality during ICU stay, and can help addresses the need for the urgent care and the availability of resource of these individuals. So to summarize this, what sort of benefit doctors or the healthcare practitioners can get out of this work? So the flame and deflame can help doctors to answer a number of clinical questions. For example, should an operative procedures be undertaken for a particular patient based on the age, demographic, and all the factors which I just showed there? The another interesting thing is if a patient whose elderly is likely to die during the admission, would the procedures even benefit for them or not? And thirdly, if a younger patient is likely to survive, can a life-saving procedures be done at this time or not? The overall the summary from these are results. You can see what we have learned so far. The mortality prediction was model that we done in this experiment based on the clinical risk factors, and that was collected from the PI and trauma patient, and we considered the 24 hours stay in intensive care unit. We just took the data of the 24 hours. Experiment result that we have show the proposed method reduce the complexity with the that we usually see in the conventional machine learning model, as we hybridize with the conventional biostat techniques, and it reduces the order list, and with less variables we need a less predictive power. The third point is the learning lesson. The proposed framework could potentially be helpful for the people, intensivists, the people, those who are working in the intensive care, in clinical decision making, also in a family counseling, like if the patient is going to die or someone is going to having some serious severe injuries, then how a doctor can communicate or better communicate or earlier communicate with the family, and limit excessive intervention and aggressive treatment like overdose, underuse of the things, overuse of MRI, or they also have these other consequences. We are all still working on that. Further, we believe that further research is necessary if we really like to incorporate more risk factors associated with PI and trauma patients to ensure the adaptability of the flame and dim flame. The part on which we are working on is mainly on the explainability. Explainability is now not a luxury. Explainability factor is mandatory. If not, is considered like as it would be soon. And so the part like based on the machine learning, if your algorithm is like predicting that, for example, if I show you should operating procedure be undertaken for a patient or not, like on which basis, on what like the variables they consider that, and based on that, it's giving us the outcomes. Unlike the conventional machine learning, deep learning algorithms, where we get the input and output, and everything is between is black box. So to acknowledge that from this work, so the people from all these universities, mainly we are working with the different hospitals, the University of, so the people, as I mentioned earlier, so in this, we have two trauma surgeons, we have people working in intensive care, pathologists, Fahad, Liaquat, and Dr. Harshad were also involved over here. So these two paper, you can, if you are interested, you can read that. This paper was published in one of the leading journals, Trauma and Acute Care Surgery. The current active projects that here, this I just would like to show if you people are interested, and I guess I already the use case purpose of to showing these two use cases for you. If you are choosing or you are in a process of for your thesis or for your for the future, that how like you can use similar kind or pick the similar healthcare domains. You see that the both use cases are very practical. So instead of detecting the some random stuff, the just cat and dogs or whatever, I'm sure you are using a more complex use cases, but going toward more practical use cases which we need in our society. So that was the main purpose. We are working on the lime detector. Lime is not common here, but over there is a tick, just like a fly. When you go out, fly just bits you, then you start getting some rashes, and the arthritis and all those stuff is going on, and it would be deadly. So this will, based on the image processing, just to take you, it will tell you whether it's just a normal tick or is a Lyme. Then we have the Augmented Pharmacy pharmacist. So this we have developed the app that you can get the drug interaction, drug food interaction, anyone in any language, because we just use the Google the Translate and other gadgets. And this is working on just like it's work on the virtual reality and the augmented reality stuff, just like you see at this time the Meta stuff is popping up, but we were working on several years on this thing. And we are also working on the LinkedIn part, in working on 2.0. One of our students is from here, is taking this project. Then we have this Severity. This is funded by the NSF, just the toolkit for the semantic content authoring and sharing. So in our group at this time, I am looking for the students, those who are interested in research and also have the background in machine learning and deep learning. We also have our from our lab, we have the startup called Medicary, and there we are working on the better clinical notes for better healthcare. And there we are looking for 1 to 3 to internship, and also looking for the senior developer working in BERT and NLP stuff. There, if you know someone or you feel that you are you want to gain some experience in deep learning and machine learning, just send me an email here. We will just take this career counseling section at the end. I always put this career counseling section, and I think in general, the chit chat, when we'll finish that, this formal talk, we definitely, I definitely like to spend some minutes on that for the students. If you have any, like, looking for some advice and help, what career you should choose, that, courses you want, what research areas, or like any advice. This I feel that, like, based on my several seminars over the years, I feel that the students here in Pakistan, they need more guidance and advice on this part. So that's what I always keep this component in my talk. And yeah, that's all. I would once again thanks to Dr. Hatter team, and it was a very great experience. I think I met with the faculty. Now I'm meeting with all of you, and hope so we'll meet after informally. And please contact me. I'm very active on LinkedIn. You can just search me with Ahmed Chan. I will be there on Twitter, just 60-70% active. You can send me the email as well. So stay in touch. Thank you so much. And if you have any question, I will try to answer.
Do you have any questions or anything?
Can I have a question?
Yes, sure.
Regarding the stats about 2012 to 2020, the patients. I want to ask that whether these stats are of all the patients around the globe or that stat is just for the US.
Do you remember slide number?
This one. This one.
Oh no, these are not the patients. This is the data set, like that. How the data from the different healthcare avenue or values are growing or increasing.
All around the globe.
That I am not sure. Here is the URL. I can. I believe that that's all. I took this stats a long time back. I don't remember.
I have a question regarding the readmission case study that you did. So the case study suggests that instead of an alternative care plan should be suggested to the patients, which would help reduce the readmission cost. But instead, the alternative care would have a cost associated with it as well, right?
Exactly.
So is it a transfer of cost, or will it actually lead to a reduction of cost?
It's you see, when you readmit that, you have to start everything again from start. They don't take their you are getting treatment here in Nust, is considered Nust hospital, right? Then you move to the Faisalabad, right? So they will start once again the procedure. Once again they start. So starting a process from scratch, the the treatment scratch, they have their several implications or others, other than the other, even other than the cost. There are several issues and problems. For example, if you go to one hospital, for example, with a bone fracture, they will ask you for x-rays from here, from there, from there. One thing is more one factor is too many x-rays or radiation exposure are bad. Second thing is, like, you are paying more and more money. So the transitionary care factor, that's what they have a lot, and they have different levels, and they send the people based on their conditions. uh, so the expenditures are very minimal. It's not, we cannot say that it's a transfer or shifting of the cost. If that would be the case, then why the people are, it's a big area of research at this time.
Sir, as you were talking about the explainability, like I was reading some articles previous before, like explainability, especially in safety critical applications of
Exactly.
learning, is not a choice; it's a necessity.
It's a necessity.
Yeah, definitely. And now the people are talking about explainable and then actionable AI. So what
Actionable is already they are. I mean, for example, you have the X-ray. Okay, you are developing an image CV application where when you put the, and you say is a COVID or not, right? So the conventional machine learning algorithm will say is COVID or not COVID, right? You will not get any answer over there. The explainability factor will tell that, like, based on these, the image which they have taken, for example, these are the spots on the, the chest X-ray, or they will give you some explanation. But at the same time, uh, we are building this. If we are building this system the for the clinicians, the doctors, they know that how significant. For example, with the people, they go with the stones, kidney stones. Sometimes, our system recognize that, even the machine learning, deep learning system, they say there is a kidney stone and maybe it's need a urgent surgery. The doctors, they know based on their experience. They know that, like, if it is minimal, if it is less than this millimeter, probably it will go away automatically. You don't need that. But based on what it will give, that coming to your answering to your question, what will give the explainability, you as a doctor and a clinicians can verify or check that whether these are the factors that they have mentioned as an explainability factor are correct or not. If it is a correct, then how you can take those steps back to to your algorithms as an extra variables to make it more intelligent to the that's what I could see. One meaning of the actionability. It could be several meaning. It's totally depend on the context in which someone has used the word actionability.
That is like designing algorithms that are explainable, and then they are like kind of enhancing your deep learning algorithms.
Exactly.
As well.
Yes,
So
that's
that's the action and like
feeding
action
back.
which they
Feeding
do
back.
and-
Yes.
Yeah.
Feeding back. Exactly.
So currently I have a small question.
Sure.
The hybrid AI CDS system work is very modern. So what kind of challenges currently you are facing to integrate it with the existing CDSS in ICU? Because
Exactly.
if you
There
are very
are
much-
one the biggest problem at this time is the acceptability.
Yes.
Right, and you see that acceptability, then you have to basically break it down. If you bring this acceptability uh, to see that who are not accepting it. Main problems, patients are not much aware. We are not much educated people, mainly the doctors, those who consider their jobs are maybe in threat, especially the radiology people. If you are getting the MRIs and you are getting the tumors and all those stuff automatically, you know, although all the algorithms, I never saw any algorithm where they are saying or that we are replacing doctors. Everyone they say that we are assisting doctor, but somehow they feel the threat. Oh, and the second part is that their strong argument is that how the system is working. I know that based on my experience, that I can look at that based on my knowledge base. I can say this is tumor or not. This is blind, this is a malignant, the or benign tumor. But they say that this is a black box with explainability factor. Now we are somehow uh, 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 trying to convince them, or in a way which probably they don't like that, but somehow we are making our case strong for them to believe on this thing. So the problem main factor is the acceptability and adaptability factor, and that would come with time. That would come, with the. There are hundreds of examples that we can quote. When the earlier the washing machine developed, the people they used to say, "Oh, it's just a maybe a." I mean, it's not good for your fabric and this and that. People are adopting that. There are hundreds of examples of that we can, the quote that the adaptability and acceptability comes with the time, and it comes with the, uh, you know, we have. I think the people of my age, we have. There was a like 10, 15 years ago. We have never seen Facebook and all those things. We are no most are addicted or used to this thing, right? And things, and the change of the things like e-commerce thing, ordering online. People have never thought e-commerce, cryptocurrency, they have, we never have thought that that would ever happen, right? So these are, I would say, these are the intellectual evolution or transition. With that, we gradually uh, see the thing, and it's not a thing we adopt the thing. Humanity always not only adopt the thing, they also discard the thing which they adopt. That over the years, if you read the history, people several, like we have a countless examples where with some action or some customs they used to be, for hundred of years, and then the people they stop that, just like fashions and all those stuff. So that's I think more of the uh, psychologically evolutionary kind of the question or the things, but eventually we are towards that.
One more option concern is that there must be some governing bodies there because it's all related to human health and human life.
Of
So
course,
what
they do
kind
that.
of hurdles you are posing with respect to that?
I think at this
FDA
time,
and
from the last 2 years, FDA they already have accepting the clinical decision support system,
Yes,
just
they
like
have
they
already.
just like they accept the disease or sorry, just like they accept the drugs, like they go for trials. Now they are drugs, just like the drugs they have the clinical trials. They already have started. And at this time, they are several hyperfine and the machines, those who are they're working on their algorithms working independently. They have placed that. Now they have put that even in insurance, like for example, if you use that x-ray automatic x-ray tumor detection system or bone fracturing system, it would, if the doctors is costing $50, maybe they will cost initially $5, $10, and that will be paid by your insurance company. So they are on that. And I think with time, soon, like after 10 years, we will see a different world.
Do you have any other questions?
All right.
Thank you so much, Dr. Ahmed. It was very nice and a thoughtful, you can say, discussion, because this is something which we are missing. There is too much work being done in different domains, but this is something which we can leverage because we have a large population. So we have like we can you can say we can generate larger data sets. Pakistan has a very large population. Connected to that, we can have better decision support systems. So this is something we are looking forward to. And if you have any other questions not related to this talk, but other like consultancy or any advice, we can resume that. I will end the meeting, the online meeting, and we can start the general discussion if you have any questions. Thank you.
जी